Dr. Lois Wagana Murithi, who is a physician and cardiologist at, of course, in private practice right here in Nyeri County. Dr. Wagana, how are you doing this evening?
I'm fine, thank you, Winnie. And thank you for having me on the show.
Karibu sana. And of course, we also have Dr. Simon Peter, who's a medical doctor, endocrinology and diabetes, right here at Outspan Hospital. Dr. Peter, first of all, thank you very much to Outspan Hospital for hosting us this evening. How are you doing?
I'm all right, and I'd like to thank everyone who is back at home watching and even our audience here. Thank you for hosting us. I hope by the end of the day we shall have had quite a fruitful exchange of ideas on how we can help our people.
Absolutely, absolutely. And of course, last but not least, is Anduta, who's a county community health as far as non-communicable diseases is concerned. She is the coordinator. Thank you very much, Anduta, for joining us. How are you feeling this evening?
I'm fine, thank you, and welcome our audience. Let's participate fully.
All right, I like that, yes. And of course, speaking of the audience, we are not alone. We have our esteemed audience right here with us at the Outspan Hospital Hall. So good evening, everyone. I hope you're excited. Are you ready for this conversation? Are you ready for this conversation? I can't hear your voice. Do you want us to stand, do a bit of exercise, bit of claps here and there? Because again, it's important. All doctors will tell you you are not allowed to remain sedentary for a long time. So we're okay, yeah? We're ready? Do we have questions ready? Okay, all right. So at the end of the day, let's have a conversation as far as NCDs are concerned, why it is important for us, number one, to know our numbers as far as hypertension is concerned. But if you are watching us at home and thinking, so how can I be part of this very important conversation? Well, feel free to interact with us on our social media platforms. Remember, it's at NTV Kenya or at Lubembe_Winnie right here on Twitter. Or you can as well join us via Facebook, and it is at NTV Kenya. The hashtag to use is hashtag #GoGetChecked, because like we said, on May 7th, we celebrated World Hypertension Day, so we do not want the conversation to end there. We continue with this conversation even here and right now. So very quickly, and I think Dr. Simon, let me just begin with you. As far as NCDs are concerned, we hear this, non-communicable diseases, very long sentence over there, but what exactly are we talking about?
Basically, NCDs involve basically take causes hypertension and diabetes, which actually from my own experience as a resident doctor, and also in our county at Nyeri are actually the commonest. Yes.
All right. And as far as the prevalence of the same is concerned, I think, Dr. Ogana, let me bring you in, because again, like we say, the country we're experiencing high, burden as far as NCDs. And today, of course, we'll be focusing a little bit on hypertension. So what are the numbers like? What are we looking at as a country?
Hypertension is, let's start by defining it, Winnie.
Exactly.
What is hypertension? Because it might be something that sounds like it's far out there. We're talking about the force at which blood reaches our organs from the heart. So the kidneys, the brain, the eyes, the blood vessels, every single organ of our body requires blood. But if this blood comes at too high a force, then that it becomes a source of harm and a source of danger. A simple example is for those who have done a little bit of farming on a nursery. If you do your seedlings, you cannot connect your hose pipe to the tap and direct it straight to the nursery, because the force or the pressure of the water, instead of benefiting those seedlings, is going to damage them. So that's what happens when the force of blood or the blood pressure is too high. Instead of giving life to our tissues, it causes damage. What are the numbers? So you did mention when we started the program that about 24% of our population has got hypertension. And these figures were obtained from some were done in 2017 in what we call the May Measurement Month. So the Kenya Cardiac Society, whom I represent, looked at a vast number, about 15,000 people were checked for their blood pressure, and a quarter of those people had high blood pressure. Out of those people, only 15% had been aware that they had hypertension. So 85% of the people who presented themselves to have their blood pressure checked had no idea that they had hypertension. The other thing about the prevalence, or how common hypertension is in the community, also goes and varies with age. So below the age of 20 years, it's less than 9%. When we get to 25 years, it's about 12.5%. When we get to 50 years, 50% of people will have hypertension. And when we get to 75 years, about 75% of people will have hypertension. And then from that level, it sort of levels out. So the older one is, the higher their chances of having high blood pressure.
Absolutely. So of course, it's a very, very important, thing for us to put in mind, because at the end of the day, we grow older, right? Every single year. So, and of course, we also need to help, the older population as well, just to understand how it is important for them to take care of themselves. We're Nyeri, right? So how about we take a look at how Nyeri is doing? Remember, Nyeri county is one of the counties that was among the 4 counties that the universal health coverage, pilot took place. So, Anduta, how are we doing? And of course, Nyeri County as well is among the high-risk counties as far as communicable diseases are concerned, right? Paint that picture for us.
That's very true. In Nyeri County, we are reading in NCD, especially diabetes, with the prevalence rate is 6.7, where the country prevalence rate is 2.3, around there. For hypertension, we always say that we read, because we have 44% of our population, that is from 40 and above, having mild hypertension. And most of them, those are now who we have screened. We don't know about the others. What can be done? Maybe we'll go up to maybe 70.
Oh, wow.
Because we always say that among 10 Nyerians,
Yes.
we have around 4 or 6 who are hypertensive,
Oh, wow.
and they don't know
Okay.
their status.
Okay.
For cancer, it's also coming up, number 3 in our NCD, because we have 33 new cases every year, every month. And a revisit at our cancer center, we have a revisit of 400 patients.
All right. So, of course, that says there's a lot that needs to be done, especially here in Nyeri. And I'm happy that we're here, even as we deliberate on these conversations, to see how best we can do. But at the same time, also, what is Nyeri doing, right, to sort of like bring these numbers down. But as far as hypertension, very quickly before I go on my guests via Zoom, Dr. Simon, so someone might think, okay, you're just talking about numbers, global figures, the figures in the country. But of course, hypertension in itself is a thing of numbers, right? So what's normal and what's not as far as high blood pressure is concerned?
Okay. First of all, it will depend on even before more numbers of the normal values. At least people need to test to know the values, but at least we can take normal pressure to be between at least 100.
Okay.
Sorry about that.
All right. Sorry.
So we can take normal values to be at least 100/60 to 130/80 as our normal.
Okay.
Meaning for someone out there who maybe goes to let's say out of nowhere says, let me get my value checked, and maybe you notice your value is, let's say, 140/80. We don't make the diagnosis there and then.
Okay.
Those ones you always keep close, try to monitor them, maybe over a period of 1 week or 2 weeks. Try to at least look at how the variations are. Try to find out about common causes of acute rises in pressure, like /maybe acute stressors or something that has just happened in their lives. But for those who have values above 160/100, those ones who may tend to monitor a bit closer, maybe give 1 or 2 days, take their values again, and if they are persistent, get them started on medication. But I think our viewers, what they need to really know is, I can't know if my value is normal or not until I actually make an effort or take that walk, go to that health center, go to that anywhere they can actually screen and get your value known.
All right.
Then that's when you can get now to know where you lie. If you are normotensive, within normal, or you're among the risky group that needs further screening.
All right.
All
And of
right.
course, that is a conversation that we're pushing today, that it is important for each and every one of us to just go to our nearest health facility and make sure that we get screened for hypertension, because like I said earlier on, that hypertension is not as silent killer. It does not have any symptoms, but patients would go to a hospital for other symptoms before they get that diagnosis that they are hypertensive. Well, let me speak very quickly quickly to Dr. Muiti, and of course we all understand how Novartis is very key in terms of just making sure that taking care of the patients, empowering the patients beyond the pill. But Dr. Muiti, very quickly, what are some of the gaps that you have identified as far as the fight against hypertension and non-communicable diseases in general?
Yeah, thank you for that question, Winnie, and perhaps you'd allow me to start by mentioning our approach towards addressing non-communicable diseases as Novartis. Being a leading multinational pharmaceutical company, we are cognizant of the fact that as we journey towards reimagining medicine to improve and extend the lives of people, we have been, we also have to be cognizant of the prevailing realities across the countries where we operate around the world. Right. And in answering your question, we have taken on an impact maximization agenda, one that I believe we've christened going beyond the pill, because we believe we've got to look at health from the point of sickness, but we've got to look at health from the point of well-being, like it is classified under the sustainable UN Sustainable Development Goal number 3. And in looking at health from a point of well-being, as Novartis, we want to drive impact in ensuring that we promote the health and well-being of people. And some of the gaps that we have realized, especially within the East African region and driving closer home to Kenya, is on many levels. We have realized gaps at the patient level, where patients are not empowered with the right information that will enable them to seek care so that they can remain healthy. Rather, patients wait until they are too ill to actually cope with their everyday activities, and that is when they go to hospital. Not from a wellness and well-being point of view, but from a point of view of wanting to address a sickness that is developing. The second gap that we have noticed largely in our interactions within the health system is on the capabilities and capacities that exist. We have got gaps within the human resource aspects within the health system. As you look at the numbers, as far as number of healthcare workers to the patient population, we are talking of numbers that are way below the WHO recommendations. So as an organization, we would want to address ourselves in being counted upon as a partner to help address that gap of the limited human resource capabilities. We've also noticed gaps in access to medicines, access to essential medicines that address the very issues of non-communicable diseases. And as Novartis, we are committed to, in line with our mission to reimagine medicine, improving and extending the lives of people, ensure that we've got strategic access programs that give a chance to every person in the population, every patient to access our innovative and access medicines at the right place, at the right time, when they need those medicines. And more to that, I believe there's still a lot that remains to be done on the policy level. We have got very good work being spearheaded at the national level by different organs and the leadership of the ministry level. We need to translate those good policies that we have into action, an action that delivers impact to the patients that are served within the health system and the population in general, so that we can then live up to the expectations of the UN SDG 3 of promoting good health and well-being, and by so doing, really combating non-communicable diseases that are fast becoming a leading killer of our populations in this part of the world.
All right.
Thanks, Winnie.
All right. And of course, very quickly, something that you've mentioned, Dr. Muiti, is that aspect of empowerment and awareness. As far as hypertension is concerned, I will ask Anne Duta to respond in terms of what exactly does empowerment look like. But before that, let me speak, very quickly to Dr. Samson in terms of how does then NHIF come? Because again, like we can see in the country, the burden is quite high. So as far as NHIF packages, what does it look like? What does it cover? What does it not? And how does NHIF come on board as far as dealing with non-communicable diseases in the country? Dr. Samson, can you hear me? Kindly unmute your mic so that we can hear you.
Yes, I can hear you now.
All right, go ahead.
Yes, I can hear you. Yes. Sir, repeat the question. I might have.
Okay, it's all right. So when it comes to non-communicable diseases in the country, of course, the burden is quite high. So as far as NHIF, how does then NHIF come in terms of helping patients ease the burden, and especially when it comes to the cost aspect of the same? All right, Dr. Samson, let's fix your connection. But Anduta, very quickly, do you want to respond to what exactly does empowerment and awareness look like as far as NCDs are concerned, but of course, especially when it comes to hypertension?
For Nyeri County, I can say that for when we talk about empowerment, we involve our community fully. We have trained CHVs, those are community health volunteers. And for Nyeri County, we have 2,510 CHVs distributed in 210 community units. Right. And a community unit is in Nyeri has a population of 1,000 people. Right. So when we say that we empower our community to assess screening for hypertension, we have given the CHVs some BP machines, and we have linked them to a facility. All right. And I think even here in Outspan, we also have a unit that is linked even to Outspan. We don't just do it to the government institution. We also link our facility to private and also the missionary hospitals, the faith-based ones. All right. Yeah.
Okay, so that is more in terms of making sure that the information is out there to the people who really need to hear this information.
Yes.
Okay.
Because one CHV has 100 household and they can screen them. They can access the services for hypertension screening available at our community level.
Okay.
Yes.
All right. Of course, you've answered my question in terms of what exactly is Nyeri County doing as far as helping people really understand what NCDs are, what role they need to take themselves just to make sure that we reduce again the burden of the same. But on a national level, Dr. Wagana, do you want to paint a picture for us in terms of how best then do we relay this information to people so that we all have an understanding that this is what hypertension looks like, this is the impact that it has, and what people need to do?
Thank you, Winnie. I think there are several entry points that we can use. One, of course, is popular television like NTV, which is being viewed very widely nationwide. The other one, which we need to look at, education from primary school, because many adults that you come across in the streets who are not in the health profession are not aware about health-seeking behavior that is healthy. They're not aware about hypertension, except perhaps if they have had a relative that they are caring for who has had high blood pressure. And the incentives that the government is doing are also awesome. Other avenues are places of worship, any place where people gather, where this information can be relayed to them. It doesn't take a lot of time, but it can have a huge impact when people are aware that they need to screen.
All right. And of course, that is more on a wider scale. But then again, what the government is doing and, together with community health volunteers as well. But for us as a people, right, paint a picture for us as far as what hypertension or living with hypertension really looks like. Because like we said, it has no symptoms at all, right? So then what is it like to live with hypertension?
So for the vast majority of people, as you said, there's no symptom associated with hypertension. Okay. A few people might have a headache that makes them seek medical care. They might have some chest pain. They might have some unusual fatigue. Once high blood pressure has been diagnosed and requires treatment, then it requires treatment for life. So it looks a picture of taking medication for the rest of one's life. Okay. And some people will say, I don't want to start medicine because if I start, I will never stop.
Yes.
But the truth is that blood pressure is like gray hair. Once you develop gray hair, your gray hair will not go away. Yeah. You can dye it if you don't want it to show, but you can't say that I dyed my gray hair, therefore my gray hair is gone, I'll never dye it again. So we can't take medicine and say, my blood pressure is now well controlled, so I can go off medication. It's something we require lifelong. Occasionally, there are certain people who are able to reverse their hypertension, and the people that we find are people who have excessive body weight, so the very obese people, and this is usually the younger person in their 30s, 40s, 50s, who has not had high blood pressure for a long period of time, who has a very sedentary lifestyle, so they sit in the office or at their workplace, they eat their mandazis and tea, they hardly move about, and take a high salt diet, a high sugar diet. So if this group of people institute a good number of lifestyle changes, they start moving a lot more, they reduce their salt intake, they reduce their carbohydrate intake, and they achieve a weight loss of about 10%, then some of them are able to reverse their hypertension to normal. But for most of us who develop high blood pressure, it is a lifelong disease. Absolutely. And it is medicine we need to take for life.
For life. All right. You know, you mentioned gray hair, and I have like a few strands, so I feel like you're talking to me. But it's all right. It is okay. It is important for us to understand. Like you say, you can diet, you can sort of like mask it, but it is still there, right? And also talking about having to be on medication lifelong. This can be a very scary thing for someone to deal with, right? So right here at Outspan, Dr. Simon, very quickly, so what is it exactly that brings patients to hospital that they end up with the diagnosis of hypertension? Very quickly, we have like 2 minutes to go on a break.
All right. In our community or at this hospital, let's say the clients we shall see, most of them will be still complaining about headache. And those are people who have, like, let's say, stage 2 hypertension, reading of around 150 over 90, right, and maybe to around 160. But most people actually won't have any clear symptoms. Most of them will come with, let's say, a different complaint, let's say a cough, but because everybody who goes into the institution to access the clinics has to be screened. So as maybe someone comes with a cough complaining of maybe something unrelated, as you're doing their vital signs, that is blood pressure, their pulses, now you pick it up. Some people are lucky to get such incidences. But at this facility, we always encourage through so many avenues. For example, we have outreach programs, at least there's patient education, they need to have your values checked, they need to really come in and not be afraid. Don't check because they're afraid of what they'll be told.
Exactly.
That I'll be told I have to be on medication for lifelong and all that. I think most of the effort that we do is actually patient sensitization, which is actually quite crucial. Through our clinics, patients who come to see us, we talk to them, you see there is this value we have monitored for this time, it's persistently high. As much as you don't have a headache or anything, it's actually vital for your health to be on treatment. And also people to understand that these drugs actually save lives. They don't actually, cause any harm. Most people will say, oh, these drugs are going to accumulate in my system, or these are going to make my body, or they're going to wear my body down. But actually, you have to understand it from a different angle. That if you leave your values high, you say you live with all these values very high and treated, you're looking at complications. But maybe a pill a day that can push your values back to normal can actually make you live longer. So you're not basically leaving to take all these pills, but these pills are actually going to prolong life, avoid complications that are so expensive to treat, renal failure, heart failure, organ failure in general. So I think most of our people, they get to actually appreciate and even encourage others to actually get and test when they know what this actually entails. So for us here, we try to really look into that, not just a matter of, your value is high, get some pills and lower that.
Get this medication and then that's it. Okay.
Exactly. Yeah, but also to encourage people to actually know what hypertension is, know what a bit of change in your life. You have now to take maybe this one pill at night or this one pill in the morning to get your values. And then these are the advantages of, taking this pill. This pill is harmless. And then regular clinics.
Absolutely. Very important. All right. Let's go on a break very quickly. But of course, when we come back, we'd want to understand, so then what is the impact of uncontrolled values? You keep referring to values in the sense numbers. Make sure that you have it controlled. And if not, what could happen? But also at the same time, then what are our individual roles so that we don't usually, always say, serikali fanya hii, serikali do this, serikali do that, all right? What can we do as individuals to make sure that we have, our numbers checked and make sure that they are at a level that is okay, all right? So we're taking a short break. Remember, the hashtag to use is hashtag go get checked. And of course, more is coming up. We'll be taking some of your questions after this break. Stay with us. And this is Town Hall Forum. See you after the break.
the day? Busy? Okay, if he really has to know, let's start with hot, nasty, fast, furious. Ooh, that's gotta hurt, but it's all cool. When cooling down is easy, this easy. Nice. You even took it with a smile.
What about yours? Furahia maisha bora.
Kuwa na mipango mbadala ya sintofahamu za maisha. Gharama za ghafla za matibabu zinaweza kutatiza udhabiti wako wa kifedha. Bima ya matibabu hukupa utulivu wa akili. Wazawidi wapendao hakikisho la maisha mazuri na bima ya gharama zao za matibabu. Pata bima ili kuhakikisha yote yatakuwa sawa.
At the first sign of pain, you need a solution that you can trust. Try Panadol Advance. With Panadol's Optizode formula, the tablet absorbs quickly and starts providing fast and effective pain relief you can trust. Try Panadol Advance.
Hi, my name is Dolly Quinta Mungai and I have dyslexia, and having dyslexia has taught me that I can achieve and be anything that I want to be. Dyslexia is a coordination disorder. So basically you might muddle up numbers, letters, you might find it difficult to read certain things that you're unfamiliar with. We need to understand that everybody is different. We are all here on an individual type of mission, on a purpose. So we should let that glow and that shine and not put everybody in the same box.
For every 349,000 that you deposit or pay as installment towards any of Optivant's plot of land, you get 10K cash back instantly. Kamata ploti na 349K. Call us on 0790 300 300.
Welcome back. This is a special town hall forum where today it's all about the burden of non-communicable diseases right here in the country. And like I said, when we started the show, according to the health ministry, now we are seeing the number of persons who are estimated to be living with hypertension are between the ages of around 18 to 69 years. So why this shift exactly? Is it that we're doing things wrong? Are we sedentary? Are we not observing our diet? What exactly is happening that we're seeing a lot more people, diagnosed with hypertension? And what can we do as individuals to make sure that, again, we hold the number as far as non-communicable diseases is concerned? Remember, we're coming to you live from Outspring Hospital right here in Nyeri County. So for those of us who are watching from Nyeri, you want to say hi, whatever question that you have, we are home. We are in your home. You want to invite us to your home as well, we'll come, okay, and eat ndumas and stuff. But important thing is for us to understand what we can do to reduce the burden as far as non-communicable diseases is concerned. So very quickly, let me turn to my esteemed audience. Everybody, are we excited? Do we have questions? Before we went on a break, everybody was like, yes, we have questions. Okay, now is the chance for you to ask questions. So anyone who has a question, please stand and ask your question. And remember, like we said, please keep the questions short and straight to the point. And remember to also highlight who exactly you're directing your question to. All right, so anyone who has a question, please stand and ask your question. Anyone on this other side? Tunagopa. Sit go home. Right? Okay, so as you prepare your questions, very quickly, Esther, I think the aspect of Nyeri County, of course, there's a lot that is happening right here in the county in terms of helping people to just get to understand the importance of knowing their numbers, right? Up until now, where would you say the progress is? How would you rate the progress as far as, the fight against hypertension is concerned? Because like we said, it's among the high-risk counties.
I would say that our progress as Nyeri County is on the community screening that is done by the CHVs. Because every year we are able to screen around 80,000 people for diabetes and hypertension at household.
Okay.
We have introduced a structure where a CHV visits a household, leaves a card, and include all the members of the family. They are screened, and they are included in that card.
Right.
If they find that somebody has an elevated high BP, they will refer that patient to a ring facility. With a referral, we have the community referral books. So we'll say that we collect our data, our main data, we collect it from our community. And then when it comes to the hospital, those who are going to be enrolled to care will be referred now to the other levels for further investigations. It is a system that works. You come from the community, you are screened, you are sent to a RIC facility, which is now a level 2 or a level 3. That is a dispensary or a health center. From there, you'll be referred to a level 4. Level 4s now are the sub-county hospitals. From the level 4 sub-county hospital, you'll proceed now to PGH, where most of our physicians are. And if the investigations cannot be done at PGH, like the ECG, we always refer to our cardiologist, who is Dr. Wagana. Okay. Though she practices privately, we depend on her service because we share a community.
All right.
That is the Nyeri community at large. So I would say that we are not far.
Okay.
We are not far. With the UHC, we were able to make some milestones. And I would say that at least we are in the path, and it is an individual responsibility. Your health starts with you.
Okay.
And in the community strategy, we say that afya yetu jukumu letu.
All right.
If we don't embrace that, you as an individual, you can't walk to a facility or go and ask your CHV to maybe take your BP, screen for your diabetes, and we don't charge at the community level. I think it is our responsibility as an individual. You take a bold step and get your BP checked.
Absolutely. It's important, you know, not just to rely for the facilities, tukishinda tukisema, hakuna madawa, you know, this and that, and yet we can do something to prevent the same. Okay, so Dr. Ogana, very quickly, and even before you respond to that aspect of fine, so this is a shared community, right? But of course you also, you know, at the Kenya Cardiac Society, then the aspect of what does then uncontrolled hypertension look like? What are some of the impact that it has on a person at the community level and, of course, the national level at the same time? Let me quickly speak to Dr. Samson. If you can hear me, can you confirm that you can hear me? Because I want to understand, first of all, how important universal health coverage is, given that we're in Nyeri. It is one of the counties that was piloted for the same. And what or how does NHIF come in as far as helping persons who are, you know, living with hypertension? What does it cover? What does it not?
Yeah, thank you. I can hear you now. Apologies for the earlier misconnection.
That's all right.
UHC, just as a background, is one of the agenda of His Excellency, the President of that's the Big Four. And it basically looks at healthcare in 3 perspectives. There's the population, there's the scope of healthcare services that are essential for that population, and there's the out-of-pocket expenditure. So universal health coverage is basically a process that is meant to achieve the coverage or the access to essential healthcare services for 100% of the population with minimal out-of-pocket expenditure. So in general, that's basically what the fund is meant to achieve through the Ministry of Health. And that's the target that we have in terms of covering about 51 to 52 million Kenyans, them accessing majority of the essential healthcare services, especially now considering that we've seen the impact of COVID and how such responses need to be well coordinated. And then we also have to consider that we are in a resource-limited setting, so we have to prioritizing what is essential and what is not. And I can tell you for now, cardiovascular conditions being the second most common cause of death in the country, it's one of the high priority areas. And then in terms of out-of-pocket expenditure, from a healthcare financing perspective, we have to look at obtaining maximum value for every shilling spent. It would be good to be here next year and tell you that for every million shillings spent on hypertension, we've been able to save X number of lives, or the quality of life has improved by 1%, or the disability adjusted life years has changed by this percentage. Thank you.
All right. Right, and of course we hope we will get there. But in the meantime, on an average, how much then is spent as far as treating hypertension?
In the last financial year, for the population that was covered under the fund, we spent a total of about 54 billion in medical claims. And of this, about 696 million was spent on hypertension alone.
Oh, wow.
So that's how significant we are looking at it. There are other cardiovascular conditions which have a significant impact as well, the likes of heart diseases, whether or not it comes with hypertension or rather with diabetes, and also chest pains and angina. So those three, we spent more than 120 million shillings in the last financial year.
Okay, all right, that's quite a lot, right? And we hope that we can, again, like you said, next year when we have such a forum, then we'll be talking about reduced numbers as well. But Dr. Gana, very quickly, Dr. Sampson mentioned, of course, a case of diabetes and obesity, which are very, very key factors as far as non-communicable diseases are concerned. Can we just touch on them very quickly?
Thank you, Winnie. A lot of times we do talk about diabetes and obesity, as we mentioned hypertension, because they have certain factors in common. The same factors that put one at risk of developing diabetes also put one at risk of developing hypertension. And one of those factors is obesity in and of itself. So if somebody has got excess, and there are grades of obesity, which we calculate based on what we call the body mass index, maybe beyond the scope of this discussion. But if you have excessive body weight for long, or for the more number of years you have excessive body weight, the higher your risk of developing diabetes, of developing high blood pressure. If you're sedentary, if you have again obesity, if you are hypertensive, your risk again of developing diabetes is increased. So they marry each other.
Okay.
A lot of times in the diabetes clinics, you find 50–60% of the patients also have got hypertension. And the older the patient, we remember again that in the community, we said at the beginning of the program that at the age of 75, 75% of the people will have high blood pressure. So as age advances, as sedentary lifestyle advances, increase in salt intake, excessive body weight, then these diseases come in together.
Absolutely, and then makes it even more difficult and expensive, like we mentioned earlier on, to manage. Dr. Simon, very quickly, in terms of then complications that might arise from a case of hypertension, and if it is not controlled, what does that look like?
The complications can be quite many. The commonest, let's say, if the pressure is too high, let's say someone missed checking their numbers, could come in with a stroke. That is when the blood supply to a certain part of the brain is cut off because of very extremely high pressures. So readings of 200, over 100 and above, or even 170, such. Other issues, other complications can also be heart failure. As we know, elevated pressures, they will kind of demand a lot from the heart. And sometimes valves tend to fail, or maybe the heart gets a bit bigger, and then now it can't function like it should. So most of them also can get heart failure. Another organ that can actually get affected is our kidney, that helps us to filter out what we don't need from even keeping a balance of our body, the drugs we take, the food we take, balancing everything that we have, electrolytes. So if the pressure is very high, also it's going to interfere with the blood supply to our kidneys. And actually, even as the NHIF people will kind of, affirm to that, in this region, you'll actually notice high cases of heart failure and actually renal failure too. Some of other cases could be, basically just think about it as if pressure is too much in your system, just think about everywhere blood needs to be supplied and potential damage that can come from there. Other organs actually left out, like the liver, still can get issues if there's a compromise in blood supply. But the common ones, like we get here in this facility, heart failure, renal failure, and stroke. Unfortunately, those who are not courageous enough because of maybe various reasons and they don't check, most of them you will notice after they have suffered a stroke. which is quite unfortunate.
Absolutely.
And yet with the medication availability now, nobody should really get this complication. Yeah.
All right. And of course, let's speak to Dr. Mwiti right about now, understanding the impact that hypertension in itself has on a person. So then, how then can we, just make sure that we do not get there? And this is as far as then screening is concerned, what Novartis is doing to help as many people out there just get to understand how important it is for them to check their blood pressure.
Yeah, thank you for that question, Winnie. And indeed, while recognizing the importance of looking at matters of health from a health system approach as well as the patient perspective, Novartis is leading a number of programs geared towards empowering the patient within the communities and where they spend their daily lives so that they can adopt healthy approaches that will help NCDs at bay, and hypertension in this case, or cardiovascular diseases, as is the subject of our conversation. And these empowerment programs for the populations extend all the way from school. Dr. Wagana did talk about the importance of incorporating matters of non-communicable diseases, cardiovascular diseases in our school curriculum. So Novartis is working with a number of partners to see that we are able to empower school children so that all the way from a young age, the population is well empowered about the kind of lifestyles they need to lead so that they can keep NCDs at bay. Looking at the more towards the adult population, we are also partnering with a number of organizations, both within the public sector and the non-state sectors, to see that we are able to take the message out there to the communities and provide opportunities for the community members to be able to be screened for the non-communicable diseases. Dr. Simon did mention about some of the outreach programs they have at their facility. And we are partnering with a number of facilities, like I mentioned, within the public healthcare system, as well as the non-public healthcare system, being faith-based organizations, as well as the private facilities. And I should really commend the great work that is being done by community health workers and community health volunteers through the strong community health systems that have been established to spearhead implementation of UHC at the community level, and say that we have leveraged as Novartis on this strong pillar of strong community health systems to then provide opportunities for screening for NCDs through regular outreaches, so that then the patients that are not able to make their way to a health facility or to a healthcare provider, for one reason or the other, get an opportunity to get a check and establish whether they are at risk of any non-communicable disease, because then evidence has shown if non-communicable diseases are addressed early, then the risk of life-threatening complications that Dr. Wagana and Dr. Simon have talked about are minimized, and the incremental complications then is minimized. And I'm sure Dr. Samson from NHIF will agree to this. Mm-hmm. So as Novartis, we are taking this approach, a population health approach, towards ensuring that we need NCDs in their bud, so to speak. Mm-hmm. So providing an opportunity at the community for patients to get empowered, get educated, get screened and referred early for care.
All right. And of course, Dr. Sampson, do you want to paint that picture for us in terms of, for example, two scenarios, one who has sort of like managed to control, their blood pressure, and one who has not and has developed complications here and there. What did this two, as far as cost is concerned? Paint that picture for us.
Okay, thank you for the question. When we look at a comparison of a person who has well-controlled pressures versus one who either is presenting late, that's a late presentation, therefore the kind of care that they need is a bit more advanced. And we use the data for inpatient visits versus outpatient visits, and also the type of intervention, be it a surgical intervention or more advanced interventions. Then an early presentation is about 2 to 7 times cheaper compared to a late intervention. We are running some more data using 10 conditions as the marker diseases for cardiovascular conditions. And this is being done through collaborations with different stakeholders, and we'll be able to better understand where to prioritize the finances. But from the data that we have at the moment, we are looking at a cost that is 2 to 7 times more expensive, depending on how the patient presents.
Okay. All right. So then there's also usually a very, big debate as far as NHIF is concerned and the coverage. For example, a person who, for example, is in Nyeri, right? And they have selected a certain facility, to get their medication or treatment as far as hypertension or any other disease is concerned. Suppose they travel, probably go somewhere else. For example, they go to Nairobi, maybe they fall sick and they need medication. There's usually that debate about you will not get access to treatment there because that is not the facility that you have selected. So can you just help people understand the aspect of you need to just go to a facility that you selected to get your medication or treatment?
Okay, thank you. I don't know whether to call it demystification, but in the benefit where members are required to select a provider are the medical outpatient, that's the medical outpatient benefit. And this is based on a provider payment mechanism referred to as capitation. So what happens is that the member is required to select a facility that they would wish to access care from a panel of providers who meet a particular criteria that has been set by the fund. Provider is paid on a quarterly basis. So every quarter, monies are submitted to the provider, and it's expected that if this member gets unwell during that period of time, then they'll be able to access the services that they're entitled to within the scope of cover at that particular facility. So it's one of the methods that is used for provider payment mechanisms, but one of the biggest challenges is in terms of portability, because once you've selected a provider, that provider is paid, then it becomes a challenge when you move to a different location and you don't change the provider. Now, to be able to address this, there are several mitigation measures that are being put in place. One of them is to protect that primary provider in the first place, because we appreciate that for non-communicable diseases, the average cost of an outpatient visit is higher because of diagnostics, because of the kind of care the patient needs, the lab investigations, and the medication. Actually, from the lab investigations and medications, it's expected to be costing about 40 to 70% of the cost of the outpatient visit. So there are several mitigation measures in place, and one of them is what is called risk-adjusted capitation. So when we have a cohort of patients in a particular area who have been diagnosed with a non-communicable disease, where we've defined the scope of 6 most common conditions in the country, then the fund reimburses at a higher rate compared to the general medical outpatient. So this is meant to shield both the patient so that they can access the whole scope of services, and also the provider so that they don't run losses in providing the services to this member. Then the other bit is performance-based payment methods. And this is meant to the member can actually access services even if it's in a different provider. Now, there are several standards that need to be set for this. So that is what we are working on in conjunction with the ministry. The other method that is being used is basically relying on the primary care networks. There is a strategy that has been developed where we define attachment and the providers go in that area. So it's expected that a member, whichever they choose, and this would be able to somehow increase the portability of the service. So that's what we are doing as far as patient services and rather the portability of the services concerned.
Okay. All right, and of course, there's usually that question of public versus private facilities as well, which I'll come back to you for that in a moment. But Dr. Wagana, of course, the aspect of it is very costly for someone to access treatment and medication, really, especially one who has more complications. But then again, there's usually that question of the pill burden, where again, research that was conducted, about 8% of people who have hypertension are on treatment, but only about to their medication. So as far as then, the aspect of taking medication every single day for the rest of your life, it's very tasking, isn't it?
Yes, it is, Winnie. And the primary thing is for all of us to understand that the goal of treating hypertension is to prevent the complications that it brings, to prevent the damage to the end organs. One of the ways that we go around it is to encourage people to start medication early. So if somebody has confirmed hypertension, stage 1 hypertension, that is between 140 and 159 systolic, or 90 and 99 diastolic, which has persisted over 2 weeks, then lifestyle measures have been instituted and the blood pressure is still not below 140, we should start medication. If we start medication early and not delay the time that we begin the medicines, the response is usually better and it is usually faster. And that way we avoid going on to 5, 6, 7 medications. The people who will refuse to start on medication or get discovered late when the arteries have been hardened by the hard pressure over years usually are difficult to control. And those are the people we find are requiring a number of drugs to treat. We have what we call the fixed drug combinations. So a single tablet will have 2 or more medications in it. So if someone is on 5 of medicine, 2 or 3 fixed dose combinations, which will then have all the 5 drugs. And what that does is that it reduces the number of pills that an individual has to take, or what we call the pill burden. Winnie, unfortunately, that also has a cost element. So the fixed drug combination tablets will cost more than some types that are single combination, single drugs.
All right, and of course then we'll come to Dr. Sampson to just help us understand then how can NHIF come in, to just help with that aspect of then the costs, that is associated with the same. But we want to take a break. Of course, when we come back, we'd want to understand, so fine, now that we know what hypertension looks like, the impact that, the complications that arise from hypertension, and of course what it has on a person as far as, the access and affordability as far as treatment is concerned, then what do we need to do, especially moving forward? But even as we take a break, I want you to just take a moment and think, when was the last time you had your blood pressure checked, all right? And how were the numbers like? And do you intend to go and get your blood pressure checked anytime soon? Do you have any fears? Dr. Simon pointed out that sometimes people are just scared because they're scared to go get their numbers checked because they don't know what they will be told. But really, when was the last time you actually went and had your blood pressure checked? And I've also posed that question. My esteemed audience right here, when was the last time you had your blood pressure checked? I'll come back and ask you, okay? And so then moving forward, let's see solutions as far as then how do we prevent the incidences, the high burden as far as non-communicable diseases is concerned. Remember, the hashtag to use is hashtag #GoGetChecked. More still to come after this short break. Stay with us.
Unapohisi maumivu, unahitaji kitulizo kinachotegemeka. Jaribu Panadol Advance. Ikitumia teknolojia Panadol Optizorb, tembe hiyo hufyonzwa haraka na kuandaa kitulizo cha haraka dhidi ya maumivu. Jaribu Panadol Advance.
Almost 250,000 people die on the road in Africa each year. Follow these safe steps and help save lives. Pedestrians, avoid using electronic devices, stay on sidewalks. At a road crossing, stop, look both ways, listen, and then. So when you're on the roads, follow these safe steps and help save lives. We all have a role to play in road safety. Together, let's make Africa's roads safer.
Matthew. Baba aliita Bahati Matthew. And in our usual nature of politicizing everything as Kenyans, haters wamesema that was the second time in a week that baba amesahau mtu wa Ukambani. And Bahati, lazima ujue.
Yes, na si ati umuulize ati wewe unakuanga na mimi juu ya nini? That's now, hiyo ni ufala sasa. That's what I'm saying. Ni wewe mwenyewe ujue. So what really motivates this person to be with me?
When I kama dem ndiye anatoka higher, meaning they are the rich ones, you know, meaning she's the one who was raised in abundance and the guy was raised in survival. There are so many
Do not hold back in any situation. Eno gets to work on the 6 symptoms of heartburn fast.
You do know you said all of that out loud, right?
If symptoms persist, seek medical advice.
NTV.
Yajayo katika NTV Weekendi.
Naomba hii Mlima Kenya yote tuwe tunaongea na sauti moja, na hiyo sauti iwe ni sauti ya Azimio.
Martha Karua asema atahakikisha kuwa Raila Odinga amekubalika kikamilifu katika Mlima Kenya. Karua na kikosi cha Azimio leo wametua Murang'a na Nyeri.
Sisi wote ni sawa, ndio tunasema hata mama mboga ako hapa.
Si uheshimu Wakamba wale walikupatia kura miaka hiyo yote. Hii kura ulipewa na Wakamba milioni 2, umesahau hiyo heshima?
Naibu Rais William Ruto akosoa mpangilio wa kisiasa wa Azimio akisema unakosa sura ya Mkenya wa kiwango cha chini.
Hiyo ni PS Interior anasema Kirinyaga ikuwe cleaned of hooligans. And I will be checking.
Katibu wa usalama wa ndani Daktari Karanja Kibicho watoa amri kwamba wote wanaotumika kueneza vurugu katika mikutano ya siasa katika kaunti ya Murang'a wachukue.
I have directed many times that no teacher in this republic should send a child back home from a day school for any charge which is legal.
Na waziri wa elimu Profesa George Magoha aonya wakuu wa shule dhidi ya kuwafukuza wanafunzi shuleni kwa misingi ya kutolipa karo.
For an exclusive fragrance experience, try Nivea Men Deep Impact Body Lotion with a long-lasting woody fragrance, deep moisture, and a fresh skin feel. Make an impact with Nivea Men Deep Impact. Nivea Men, it starts with you.
You know, there's this notion that golf is difficult.
If there is one thing that you will pick up from golf, it's patience, persistence and focus.
Advice that I'd give to people who want to start playing golf is to start.
And I assure you, you'll be addicted before you know it.
But I know that meat looks tender, but maybe not so much when your chest is burning. Remember what happened the last time? Hey, dude, you don't listen, man. Are you testing yourself? I tried looking out for you, bro. Hey, you see now? How's the heartburn? Look now, it's burning.
Do not hold back in any situation. Eno gets to work on the 6 symptoms of heartburn fast.
You do know you said all of that out loud, right?
If symptoms persist, seek medical advice.
Who is a true partner? They go out of their way to help you. They do not hesitate to go the extra mile. And they're always there standing beside you. They step in when you need them the most. Because a true partner is a partner kwa ground. KCB Bank. Go ahead.
Let's get straight to it. Ready for whatever. We gon' ride. Line 'em up. Let's go toe to toe. Tell 'em pick a side. Put in work. We don't play no games. Watch him run in high. Savage mode. We gon' keep it G. Yeah, you know.
When cooling down is easy, this easy. Nice. You even took it with a smile.
What about yours?
All right, welcome back. Glad you're still with us. This is a very special town hall forum where today we want to understand the burden of non-communicable diseases in the country and what our individual roles are as far as just using this burden, reducing the incidences as far as the new cases of hypertension and, of course, in turn, again, contributing to high levels of non-communicable diseases right here in the country. So very quickly, let me go to my esteemed audience as far as questions. I know a lot of us, we have so many questions, but then again, we're very limited in terms of time. So very quickly, to those of us who have a question, please keep your questions very, very short and straight to the point. And of course, we have a lady over there. Thank you very much. What is your question? And who are you directing your question to? All right.
Tawagana. Was there an immediate effect of COVID on NCD burden in the country? And is there a difference in the approaches to management as a result of COVID? Thank you.
Thank you very much. Very, very good question over there. Very short to the point. All right. Anyone else who has a question at the back? I know we have two. All right. Go ahead. Any of us can start. Please stand and indicate who you're directing your question to.
Okay. My question goes to Dr. Agana. You've just told us that hypertension is like gray hair. When you have it, it can go away. Yet we know we have gestational hypertension. Does it go away at a point, or what happens?
All right. Good question. One last question. One.
Is basically to Dr. Simon Peter. The role of history, family history, medication history in diagnosis of hypertension.
All right. Very, very good questions over there. All right, Anne, do you want to start us off? Okay.
Yes, there was of COVID.
Go ahead.
In general.
All right, let's change your mic, Dr. Simon. All right, thank you as we sort that one out. Okay.
For Nyeri County, we were hardly hit by COVID, but we went into action very fast. People were not going to the hospital. We closed the clinics, the MOPC clinic, and people were just afraid of going to the hospital because of the COVID. They thought that COVID is in the hospitals. But with the time, when the vaccine came, Nyeri was the first one to go for the outreaches, community outreaches, and we used the CHVs, we mobilized our people, and we were able to cover it up, so we can say that we were even able to reduce our mortality. Initially, we had so many people dying. In fact, I lost 15 CHVs because of COVID-related. And that is now the workforce that we were sending there in the household. And I can say that after COVID, now we are here. Wave 6 is coming, but people are still behaving like there's no COVID. And if you have the NCDs, your immunity is compromised. When COVID comes, maybe Dr. Wagana can tell us the correlation between COVID and diabetes, because most of the people that we lost were diabetic patients.
Okay, all right, Dr. Wagana.
Thank you for that question. For these questions, actually. If I start with Anne's question, the correlation between COVID and diabetes is complex. One of the direct effects is the medication that we were using for moderate and severe COVID disease. So we used a lot of steroids, which can precipitate diabetes. COVID in and of itself is a diabetes precipitating disease. So that also increased the incidence of diabetes. In relation to the other NCDs, there was a lot of stress during the time of the COVID epidemic and pandemic. A lot of people were not moving as much, so we became much more sedentary with the curfews, with the travel restrictions. We started eating more at home because of spending more time in the house. So some of these over time may play into a higher incidence of NCDs, hypertension, diabetes. We may not see the direct effects immediately. On the positive side of things, people began to embrace online consultation. So some of the practitioners are now able to see patients without having to have a direct physical contact, which is good. stock-ups of medication was encouraged. So we encouraged our patients to go to the chemist and buy their medication even if they don't appear in hospital. So to some extent, it also helps to reduce some of that negative effects. Job losses, the economic impact of COVID, unfortunately, is likely to be associated with high NCD incidents.
On the same. All right, and of course, there was a question I think directed to you as far as that's analogy for the gray hair.
The gray hair and the gestational diabetes.
Yes.
Thank you for that question. Gestational diabetes is a completely different disease. Strictly speaking, it is gestational hypertension. It is hypertension or high blood pressure that comes as a result of the placenta's presence in the body. So usually gestational hypertension or hypertension, what we call preeclampsia or eclampsia, resolves after delivery of the placenta. So that normally will go away. But sometimes hypertension has been pre-existing even before conception, so it is discovered during pregnancy. And sometimes that distinction is not very clear, whether this is a new onset of hypertension as a result of the pregnancy, what we call the pregnancy-related hypertension, or it is pre-existing hypertension discovered during pregnancy, which does not disappear after delivery, it tends to persist.
All right. Okay, and then very quickly, Dr. Simon, there's a question for you.
The question I had, it's about the role of history taking in those who are diagnosed. It's very crucial. For example, just if I may echo what Dr. Wagana just said, like for those who have gestational hypertension, sometimes, yes, after 6 weeks it's gone, but then it leaves you with a 50% chance of generally in your life getting hypertension. So as we are busy, getting some more information from these people, you get to get that. And also through history, you can get to know someone's lifestyle. Let's say alcohol intake, which has actually been one of the main precipitant to people getting hypertensive a bit earlier than, let's say below 35 or even below 40 in general, excess alcohol intake or even smoking itself. So history is very important. Another thing, maybe still for the line of ladies, the commonest precipitant also could be OCPs, like the pills we take for family planning. You find maybe someone already weighs a bit more than they should for their height. They are already overweight. They are using these pills as a form of family planning. But as we know, usage of these hormones can also precipitate to getting hypertension a bit earlier. So history is always important. As for doctors and all the other health workers, they know how important it is. The second part was the role of medication history as well, which I've covered for OCPs, but we have common painkillers. Basically, we find this in people with chronic pains. You find especially drugs we call NSAIDs, and non-steroid or anti-inflammatory drugs, the likes of ibuprofen, the naproxen. There are so many, and are available on the market. Okay. And I could say, I don't know if it's fortunate or not, most of these drugs can be accessed basically by just walking into a chemist and say, I have a headache. Then you are given like Maramoja or you are given diclofenac. Chronically staying on these drugs can also precipitate. Basically, precipitation means if you chronically use these drugs, you could find yourself with high blood pressure a bit earlier, or even these drugs being a main cause of blood pressure, either directly or even through renal damage, what we normally see.
Okay. All right. So we literally have like 10 minutes before we bring this discussion to a close. Time flies, I know. So let me start with Dr. Muiti very quickly. So now, of course, that we understand what hypertension, of course, non-communicable diseases are all about, what we need to do, our role, and of course, the impact that it has on a person's life. The question is then, moving forward, do we have, a chance that we can have new technologies emerging that will help patients as far as, managing their blood pressure and also just to reduce the aspect of pill burden? Do we have a chance that we can have, something more easier to encourage the patients to adhere to their medication?
Yes, I would say as a start to my response to your question, Winnie, and the evolution of interventions available for addressing these non-communicable diseases is progressing very fast. And as we look at that evolution and its fast progression, we're looking at what we can be able to do to make the life of the patient receiving those interventions better in terms of efficacy of those interventions, and have interventions that have a lower level of side effects. So we indeed, within the pharmaceutical industry, a lot of innovations that are currently under research, and also innovations that have been brought to the market. And there are those that are already included in the WHO essential medicines list. So yes, there is hope. There are interventions that are currently on the market, being accessed by patients, being administered by the healthcare providers, and there are interventions that are just about to come to the market, and there are interventions that are in the research pipeline. And the beauty about the evolution of of medical interventions is they keep getting better with every step of evolution forward. So yes, indeed, there is hope, but even beyond the medicines and the interventions, I would want to say that all of us as players in the ecosystem, within the healthcare system, need to have a patient-centric approach, so that then whatever level of intervention we are at, we are working towards delivering interventions that will make the life of the patient and the population better.
All right, I like that. Thank you very much, Dr. Mwiti. And of course, Dr. Samson, very quickly, as far as NHIF is concerned, do we have plans that then we can expand the cover to even cover some of this medication that sometimes can be a bit costly, especially for those ones who have a bit of complications here and there?
Thank you, Winnie. Yes, when it comes to medication, we have a plan on covering the essential medicines, and then there are those orphan or specialized medications that are required for a number of conditions, including hypertension. So to be able to do that, we've come up with a concept on that is aligned to health products and technologies. That is a document that was done and released by the ministry. It's a strategic plan 2020-2025. And in line with this, we are coming up with a pharmacy benefits package that is meant to shield the beneficiaries from the costs of some of these medications, which on average are significantly higher compared to the rest. The other initiative that we are taking is to maximize on technology when it comes to management of some of these cases. It has implications in terms of cost, but when it comes to the return on investment, then we get better value out of every shilling spent on hypertension. And of course, as was mentioned earlier, the prevention bit. Everybody has a role to play in terms of preventing it in the first place, and early diagnosis and linkage to treatment. And then, of course, maintaining on early optimized therapy.
Absolutely. It's all our individual responsibility. Okay. And then, Anduta, very quickly, in terms of then tracing patients, because like we said, sometimes there are patients who, once they have like their blood pressure sort of controlled, they do not take their medication anymore. So that aspect of then tracing these patients and making sure that they still stay on their treatment, what would you say very quickly? What are some of the measures that need to be put in place to achieve this?
I would say that it is an individual responsibility, because once you are told that you have hypertension, the next thing is you decide whether to take the medication. Just know that it is your life. Okay. And even if we help you to take your BP at the community level and you are still not taking your medication, there's a stage that we live and we say that take your life preciously, because you only live once. And there's no spare. Yeah, there's no spare for life. If you can't take your body to the garage, take care of it. Okay. Be healthy.
Oh, I like that. Okay, and it's clear we can't, we really can't take our bodies to the garage. So I like that. Make sure that you take care of it. It's our individual responsibility. And of course, Dr. Simon, as far as then getting to that point of managing your blood pressure, right? And even for those ones who again have not been diagnosed yet, how often then should we check our blood pressures, at what point, and who exactly, right? Especially for those ones who are more at risk of probably hypertension. How often should we check our blood pressures?
My advice would be at least for those who are 18 and above, but more especially those who are 35 and above. at least a health facility, that this one that offers blood pressure check, around 8 checkpoints free of charge. It would be routine at least. Let's say if you went and your value was okay, for most people they'll say, okay, maybe check again next month, especially for those who don't have like, let's say sedentary lifestyle, or who don't have risk factors, who are not heavy alcohol consumers, who are not smokers and that, then you can check maybe once a month. But those who are, let's say, with bad family histories, maybe it's because some people will come concerned, oh, my mom had pressure, then she died at 50. Then I've come in to see that, you know, I don't have this. So those ones we encourage them to check a bit sooner, maybe like every 2 weeks, get your value checked.
Okay.
And the health workers actually always, you know, advocate for now the frequency actually. Like if it's stage 1, let's run it for 2 weeks, look at these values. If they're persistently high, take a pill, and it will actually make sure things are okay.
All right,
Yeah.
I like that. Okay, and then of course, Dr. Wagana, very quickly, in terms of number one, because I do not want to believe like all is lost, right? We want to end on a positive note. So for those ones who are currently living with hypertension and thinking, well, so then what do I do? What are some of these changes that I need to make just to make sure that I have my, you know, blood pressure controlled? And then also number two, in terms of implementation of some policies, just to make it easier for the patients and just ease the NCD's burden in the country. What would you say?
I like hope. Hope does not disappoint.
Yes.
So the first thing is to understand that if you do obtain good control of your blood pressure to target, that is 140, 90 and below, then ideally, and that happens early, it's diagnosed early and the control is achieved, you will live your normal lifespan without having to be inconvenienced with admissions or dialysis or those kind of complications. So that gives us a lot of hope when we're giving people medication and also taking their medication. We encourage patients to check their blood pressure. If you're able to afford a machine, it is useful to have one at home, because then you're able to do 2, 3, 4 times a week, have your blood pressure diary. When you see your healthcare provider, then you have that, and it is useful. On a larger scale, we're looking at managing hypertension risk, managing risk in our communities. We need to ensure that people are moving much more. So we need to hear the message of moving much more, avoid sedentary lifestyles. Now we have motorbikes that drop everybody at their doorstep. And so we are less and less mobile. So look for an excuse to walk. And how much walking are we talking about? That is about 30 minutes, 5 days a week, so that you're doing 150 minutes in a week. Some people would prefer to break it down to 45 minutes 4 times a week, which is okay, but keep moving. Move more than you have been doing before. A reduction in our intake of salt. We have salt everywhere. We boil eggs, we add salt. We fry eggs, we add salt. We make our githeri, we add salt. Some people even add salt to arrowroots. So we need to reduce our added salt in food. And as we prepare our food, we can put the salt there, but avoid table salt. Complete cessation of intake of tobacco. So that is cigarettes or electronic cigarettes, shisha, etc. Because tobacco hardens the arteries and makes blood pressure more resistant to treatment, and also increases the risk of complications, particularly strokes and heart attacks.
All right, I like that. And I like the fact that we're all speaking hope, which is very, very important. It means all is not lost, and you can all take charge of our lives just to make sure that we remain healthy. And for those of us who are living with hypertension, again, all is not lost. Just make sure you adhere to the medication so that, again, you're able to control your blood pressure. So we have to, unfortunately, put an end to this conversation. I hope that you've learned a lot, and we, just pledge really to make sure that we take charge of our health. So I just want to say very quick thank you to my panel, Dr. Mwithi Makathimo, who's head Public Affairs Partnership and Programs East Africa Cluster. This is at Novartis Global Health. Thank you very much, Dr. Samson Kuhora, head of Benefits, Design and Claims at NHIF. And of course, not forgetting my panel here, Dr. Lois, a physician and cardiologist, and of course private practice, but of course in Kenya Cardiac Society, as well as Anduta, County Community Health and Cities Coordinator right here in the Department of Health, Nyeri County. And of course, last but not least, Dr. Simon Peter, medical doctor, endocrinology and diabetes right here at Outspan Hospital. Thank you very much. for your contribution today. My name is Winnie Lubembe. Special thanks to our Span Hospital, of course, for hosting. But I cannot forget to say a very big thank you to my esteemed audience who have been, amazing in terms of the questions and also just participating. So can we appreciate ourselves even as we say goodbye? Let's appreciate ourselves. All right. And of course, to that, those of you at home, thank you very much as well for watching. There has been a special town hall forum where, of course, we were discussing the burden of non-communicable diseases in the country. Thank you very much. God bless. Have yourselves a lovely evening and enjoy the rest of your viewing. My name is Winnie Lubembe. Goodbye.
Ladies, what is most important to you when buying lotion?
Smoothness, scent,
glow. Why pay more? Get great quality at an affordable price. It's just nicer and lovelier. Chagua, Kenya's #1 body lotion.
1, 2, 3.
Hi, my name is Dolly Quince Mongai and I have dyslexia, and having dyslexia has taught me that I can achieve what I want to be. Dyslexia is a coordination disorder, so basically you might muddle up numbers, letters, you might find it difficult to read certain things that you aren't familiar with. We need to understand that everybody is different. We are all here on an individual type of mission, on a purpose. So we should let that glow and that shine and not put everybody in the same box.
Every 349,000 that you deposit or pay as installment towards the end of Optiven's plot of land, you get 10k cash back instantly. Kamata Bloody 349k. Call us on 09 300 300.
Red Bull gives you wings.
One, two, three.
This is NTV.